It's a ghastly picture I gave you, isn't it? I mean, uh, it looks like it's a
Good evening, everyone, and welcome to tonight's primary care seminar hosted by the Primary Care Education Department at City St George's University. My name is Roa, and I'm a GP and clinical lecturer at City St George's. So tonight we are shining the light on cancer and its diagnosis in primary care. In the UK, primary care serves as the front line for cancer detection, playing a pivotal role in early diagnosis and in turn patient outcomes. We're so pleased to have Professor Willie Hamilton joining us as our speaker today. Professor Hamilton is a distinguished expert in cancer diagnosis and currently serves as the Professor of Primary Care Diagnostics at the University of Exeter. His extensive research has been instrumental in developing resources that assist GPs in identifying symptoms associated with major cancers. Notably, he was on the clinical lead for NICE's referral for suspected cancer guidelines published in 2015, with half of the recommendations stemming from his research. Professor Hamilton also developed the cancer risk assessment tools, which quantify the risk of symptoms linked to different cancers, aiding in earlier and more accurate diagnosis. In recognition of all of his significant contributions to cancer diagnosis, he was awarded a CBE in the 2019 New Year's Honours List. Today, Professor Hamilton will share his story and insights into his journey with cancer diagnosis in primary care, focusing on early detection and its impact on survival rates. Without further ado, I'll now hand over to Professor Hamilton. Please do use the Q&A box to submit your comments and questions, which we'll pose to Professor Hamilton at the end of the seminar. So I will just hand over now. And if you could just unmute yourself, you're good to go.
I have done so, and now I need to share my slides, and then we are cooking on gas. That looks good to me. Can everybody see that?
That's great, thank you.
Brilliant. Okay, well, thank you one and all from St George's for inviting me to talk about what's been a significant part of my life for 25 years. And you gave me the title, actually, Early Detection Survival Impact, Revolutionising. I never revolutionised anything, but I'll do my very best to just nudge things along the pathway. And you can call the revolution if you like, but you're wrong. So without any further ado, let's move forward. Right, so that I was hoping I next slide, and I'm finding I can't. Yes, I can. That was easy. Yeah, I mean, it's clear that early cancer diagnosis has been important for quite a long time. That book on the left, which is sitting on my behind me at one of my shelves, you can see it cost me a mere 12 and 6, or at least should have cost me 12 and 6 if I'd been alive in 1955. Actually cost me 4.50 at a second-hand bookshop. I should have clearly someone should have bought a whole pile of them and made a profit. But then look at this other Pulitzer Prize one in 2011. It's a jolly good read, The Emperor of All Maladies. But this just says that for 70 plus years, it's been recognized that the earlier you diagnose a cancer, the better things go. So I'm going to give you about 3 nasty slides that I'm going to have to walk through. This is the first one. And the good news with this one is don't try and remember it. If you want, write down the reference down halfway down the slide, but don't try and remember this slide. We've actually struggled to say how much earlier symptomatic diagnosis matters. Now, this paper, I had nothing to do with it, so I can really heap praise on it. It used the COVID data to see how much survival loss there was, so survival disbenefit there was by delays induced in the COVID era. Now, to be fair, inducing a delay is not quite the same as making things, expediting a diagnosis, but it's not far off it. And what it does, this particular slide, gives you the amount of worsening of survival for every 2 month period, um, split down by age and by cancer site. This was a giant modeling exercise. I don't remotely understand it, but I believe it. And you just looking at it holistically, you can see there's a lot of red, there's a fair bit of orange, and there's a wee bit of green. And green, in fact, means delay doesn't matter as much. And if you look at the bottom, there's testis and thyroid, and certainly pulmonary carcinoma of the thyroid and testis are both extremely curable even after metastases. So in these cancers, early diagnosis doesn't make a great amount of difference. But overall, in my fourth bullet point here is if you want a really broad figure of how much survival loss there is by delay in diagnosis, it comes out about 1% worse survival per 1 week of delay. So if when I was working as a GP, I've stopped now. If I missed, and there's a nice emotive word, if I missed a cancer for 4 weeks, on average, that patient would be 4% worse off in terms of their chance of surviving long term from their cancer. So that is a useful paper to look at if you really want to see just how important it is. But it's not just academic work that thinks it's important. It matters to the media, it matters to patients, and to doctors. And it seems to matter to Catherine Zeta-Jones. This is the sort of headline that we GPs dread. The Daily Mail is the leading experts in clobbering us GPs, but these come out about every 2 or 3 months, where we are perceived as having let the public down. And if you don't believe me, that took me about an hour to compile. Everyone is about cancer somewhere or other. Not everyone is about GPs apparently letting the system down, but you can just see that it sells papers, and it sells papers if you can say that the profession is not up to scratch. The one that really terrified me is that they've obviously been in my university offices. Look down at the bottom right. Could your fridge kill you? Well, there's no doubt that my fridge in my university office could kill me. Whether it'll be cancer or will be infection, I'll leave that one up to you. But joking apart, yeah, this is a big story for the media and for the public. So what you want to know, I think, is what will help in improving cancer survival. And the main area that I've worked in is symptomatic diagnosis. And I want to start with a little thought experiment. Now, we haven't got the ability for me to see if you put your hand up. So if you're sitting in your living room at home, or still at the end of surgery, or wherever you are, I want you to put a mental hand up if you've experienced headache, fatigue, or cough. There you are, in the last 24 hours. And I'm going to put my hand up for fatigue. You can actually see my hand. And I bet some of you have got your hand up for cough. But each of these is possibly cancer. We all know that cough can be a harbinger of lung cancer. Fatigue can be a harbinger of any number of cancers. And headache can be brain tumors, of course, but nearly always isn't. So it's actually important to know not just what the symptoms of cancer are, but how important they are. And this again is a wonderful paper. And again, I have nothing to do with it, so I can heap praise on it again. This tells you an idea of the symptom pyramid. And this is an American paper and it uses American data. My next slide is a British paper. So bear with me, we cross the Atlantic. So of 1,000 people, 800 of them will experience and even report symptoms either to their family or other people in a month. And so those of you who have put your hand up to my previous slide, you're in the majority in that symptoms are really common. So 327 of these Americans consider seeking medical care, and 270 of them actually visit a doctor. And in America, because you can go to various clinicians, you don't have to go to primary care first. It's 113 of these Yanks are visiting a primary care physician's office, and a further 65 are going to an alternative care practitioner. I don't have the figure for that here, but it wouldn't surprise me if for every 2 GP visits, there's 1 visit to a non-medical practitioner. And 21 of these Americans of the original 1,000 actually end up in a hospital outpatient clinic. 13 of them go to an emergency department. 8 of them actually end up in hospital. And 1 is hospitalized in an academic medical center like Georgia's. So that is this sort of, they call it the ecology of medical care in this paper, and I call it the pyramid. That as the symptoms progress, you get further and further up the medical care system, but fewer and fewer patients do. So let's change that to just from any old symptom to cancer-related symptoms. So now the first change in this is not just from America to Britain, but I've changed it from a month to a year. And I'm now talking about symptoms that may be related to cancer. It's like the symptoms I gave to you 2 slides ago. So again, in this time, the 1,000 people, 800 of them will experience a symptom enough to discuss within their family that could possibly be cancer. It's and actually funny, it's the same figure. Consider seeking medical care. Many of these symptoms go unreported, and many of the symptoms that are reported to medical care go unrecorded. And the example I've put here is that somewhere between a sixth and a fifth of patients have rectal bleeding in any 1 year. So probably somebody on these calls had rectal bleeding in the last year. 129 of the original 1,000 people have a GP record of a cancer symptom with a risk of cancer greater than 1%. And 43 of this 1,000 people have a 2-week wait appointment, and 6 will have cancer. And of those 6, 1 or 2 will present as an emergency. So same slide set as the previous one, but for cancer and for a year. And as you know, and as Roy kindly said, I was heavily involved in producing the NICE guidance in 2015. But I think one of the key points that is so often forgotten by people, particularly when they're talking cancer statistics, there is not one symptom or feature of cancer for which cancer is more likely than not. It's not cancer is more common. I give you a fungating breast lump. I think we've seen we haven't seen fungating breast lumps. They disappeared when I was a medical student. But I cannot think of a cancer symptom, and I'm even calling it cancer symptom, where actually benign disease is not more likely. So the problem is this guidance focuses on cancer and rather ignores the fact that for the symptom, other things may be relevant. And that is one of the best arguments for cancer symptoms coming to a GP, because the GP will have the skill set to look at other causes of the symptoms, if possible. So the whole idea of NICE was written for GPs. Yes, it was used to encourage secondary care to adapt their response to capture things that GPs were sending, but it was primarily for us GPs to use. GPs aren't bad, despite what the Daily Mail says. This is the second tricky slide, and this one is actually harder to explain. So if you'll forgive me, I'll walk you through it as if you're idiots. There are 6 slides here on the right. Each is a different cancer site. in each one, let's go to the second down on the right, prostate. Okay, it's about 3/4 of the way across the slide is a upward dotted line. That is 2015 when we brought in the NICE guidance. And the waving graph with confidence intervals in light grey is, and now this is the tricky bit, compares symptoms that were brought in for the first time in 2015, their times to diagnosis, against symptoms that were always in guidance, in particular in 2005, the previous NICE guidance. So breast lump is your comparison, because that was in both, and a mixture of cough and raised platelets, shall we say. So I mix my cancers up, but I think you understand what I mean. New symptoms brought in is what we're measuring, and we're comparing the time to diagnosis of new things against old things. And if the graph drops, then the time to diagnosis of new things is improving against the benchmark of old things. So if you look at these ones, the easiest one to see is bottom left, colorectal. It was coming down. It was getting better, and then probably improvement accelerated after we published. And that was probably because GPs were actually referring more and more, because colorectal is such a difficult cancer, in that so many colorectal cancers don't have rectal bleeding or don't have severe anemia, and you have to refer on milder symptoms. And of course, FIT has transformed that completely. But it does look as if in 2015 accelerated the GP behavior to make referrals on lower risk symptoms. It go back to my prostate one, second down, and on the right, it's clearly taken a dip down. Uterus bottom right, it's probably taken a dip down. Lung hasn't changed, I would say. And I think lung hasn't changed because we've had chest x-rays all the way through. And actually, we GPs were pretty good at recognizing when a patient with respiratory symptoms just might have a lung cancer. We were doing chest x-rays in a pretty sensible way, and that didn't change much in 2015. Bladder may have improved, but overall, when you did the stats across all the cancer sites, there was a clear signal saying that GPs were using NICE guidance to bring in the new symptoms and refer them earlier and have those patients with cancer diagnosed early. Forgive me making a meal of describing all that. I can't see your faces, and I can't see if your jaws have dropped and or you've dropped off to sleep. But I hope I've explained that correctly. Now, how about thresholds? You know that NICE brought in a threshold risk of 3% for the patients to be urgently investigated for cancer, either in-house or by referral. It was thought by governments after NICE, did NICE get it wrong? And we maybe did. They wanted to know what would happen if we had used 2% and if we'd used 1%. And this box describes that. We got a data set of 150,000 patients from anonymized GP records, looked at 1 year and 11 cancer sites. So I happened to pick 2016. I can't remember. There was a good reason why we did it, why we did 2016. And that is the number of patients who have a symptom of cancer in the records, and that symptom equates to a cancer risk of greater than 3%. So 5.6% of the when I say whole population, this data set was over 40. So 5.6% of over 40s get that symptom. Now, you'll be surprised with this next one. If you drop the PPV to 2%, it actually only goes up a tiny bit. And this is simply because there were very few symptoms which carry a risk somewhere between 2% and 3%. I think this was some of the gastrointestinal ones were in that gap, but there are very few. So actually, the politicians might do a nifty move some point. Say, "Wow, we're going to ask NICE to drop to 2% because they want to get votes for appearing to deal with cancer well." And to be honest, that's exactly what the politicians do. And this question has come up from the politicians that this work was a direct request from Number 10, and of course they were wanting to get votes, and I was wanting to get people cured of cancer. So we were actually aligned. I'm not saying who it was or which political party it was, but any one of them would be able to do it. So it would be a dead easy politically to drop to 2%. I don't know how they didn't, but actually would make naff all difference to us identifying cancer earlier. But if you go to 1%, nearly 20,000 patients have a 1%. So if you did that, you're actually more than double the number of patients eligible for urgent investigation. So if we are to go down further, we have to, at the same time, bring in ways of investigating patients much more easily and much more cheaply to do that. So FIT has done that for us. We had already dropped our conversion rate in colorectal clinics down to between 1% and 2%. Some places actually below 1%. But bringing in FIT at least has allowed us to do that, so we can carry the risk in general practice rather than having to refer them. So that's investigating thresholds. The next question that comes up, and we were able to use the same data set, is, well, do patients with a 3% cancer risk symptom, so a woman aged 55 with a breast lump, she's well above 3%. Does she have other symptoms which are lower risk earlier, that if you lowered the threshold, you would identify her earlier before the lump developed? Now, again, maybe breast isn't the best example. Maybe lung or colorectal or pancreas is better. That can you be simple? Do people start with low risk symptoms, move on to middle risk symptoms, and then move on to high risk symptoms, and then the bell rings and somebody diagnosed them? Here's the answer to that question. So there's the same people with the 3% risk that we looked at in a previous study. Would you believe that only 4% of them had an earlier 2% risk? Well, you probably will believe that because I told you there aren't that many 2% risks. So that's no surprise. But actually, not that many of them had a 1% risk either. So the idea somehow that we can stop people progressing to obvious cancer by identifying them when they don't have obvious cancer but do have some risk, it doesn't wash. So in effect, instead of this being a state progression, it's just a line of spaghetti, the way people's symptoms go. They go from high risk back to low risk and up to high risk and down. So you can't just simply think if we investigate all the nice low risk symptoms, we'll identify everybody earlier. That doesn't work. At the same time, patients want to be tested. If you ask patients, and this is exactly what we did, I was involved in this study, if you give patients a description of symptoms which equate to risks of cancer, and we used 1%, 2%, 5%, and 10% in these graphs. You can't see that. The left one is 1%, and then describe what the testing involves, and then describe what your chance of surviving cancer will be. Patients will say, yes, 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 I want tested, almost irrespective of the risk. When we designed this study, we assumed there would be the sort of ladder up of willingness to be investigated against risk of there being a cancer that is shown in the red slide, in the red one there. But actually, in lung and pancreas, and I wrote in the vignettes, if you get lung cancer and we diagnose it, there's no great chance of survival. And the same thing for pancreas. They still said, I want to know, I want to know, I want to know. And that bottom bar, for each of them. The leftmost bar for each of them is a 1% risk. So patients want cancer testing. I think the only reason we got a slope on the colorectal one was I described colonoscopy, and more accurately the preparation to colonoscopy, rather too graphically. And I think people were terrified of the prep, and I don't blame them for that, rather than actually necessarily wanting the test. So there's a gap here between what patients want in terms of cancer diagnosis and what's on offer in the NHS, and how can we bridge that gap? Well, let's describe it first. There's three groups of patients who suffer badly from from bad luck, but you have to deal with bad luck within the NHS. The first group is the invisible patient. And that's the patient who has chosen, and of course they haven't chosen, the wrong symptom for their cancer. And around 30% of cancers begin with a non-specific symptom. Now, when I use the term non-specific, I mean a symptom that, if it is cancer, could mean any one of a number of cancers. So something like weight loss, or appetite loss, or mild anemia, or bellyache, where if it is cancer, it could be any one or different cancers. And 30% of cancers, some people will even say up as high as 50% of cancers, start off with a non-specific symptom. And those symptoms are low risk. But as I say, you must lie, not no risk. And there's often no primary care test for it. Bellyache, for instance, there's no primary care test for cancer in bellyache, with the exception of FIT. On occasion, of course, they've been tested, and the test has been normal. And these poor patients turn into this, the ping pong patient. And again, it's non-specific symptoms, and I've listed possibilities there: abdominal pain, weight loss, thrombocytosis, so your raised platelet count. These patients are called ping pong patients because they used to bounce from one specialty to another. And I think we've all had them, particularly with pancreas, where you just can't be sure, but you're fairly sure there's something wrong. And they used to go off to the gastroenterologist or the surgeon, and then they'd have a colonoscopy up, and they'd have a gastroscopy down, and then finally someone would do a CT abdomen, and boom, there was your thing. And I've got another slide later to show how we can solve this problem and have, to an extent, improved this problem. But the ping pong patient still exists. And then here's the odd one, the bullseye patient. And this is a patient with the right symptom for the cancer. But I may have got it wrong in writing the preamble to the NICE guidance. I wrote this. Look in the little red box down the bottom, and I'll read it to you in case it's too small. Exceptions, and that means to the recommendations, will occur, however, and clinicians should trust their clinical experience when there are particular reasons that this guidance does not pertain to the specific presentation of the patient. Now, that was my get out of jail free card for GPs, to allow GPs to contact the specialist and say, look, I just don't like what's going on here. I can't tell you specifically why I'm worried about he's got this or that or the other, but I'm just concerned this guy's got cancer. And to me, that is 100% legitimate referral. And that's what I put that red box in for. But do we GPs use the red box correctly? And this is a study we did post 2015, actually, we did about 5 years ago, and it caused all sorts of mayhem in the press. We looked at patients with these 6 symptoms in the middle: the dysphagia, postmenopause bleeding, iron deficiency, anemia, rectal bleeding, hematuria, classic symptoms that you would all expect if you write them in the notes. You would make some attempt to diagnose cancer in your patient. And this is what we got. That actually only 21% of patients with anemia severe enough to receive a 2-week rate referral actually received one. And breast lump was 66, and whatever dysphagia, 20% of dysphagics. So GPs were clearly using their wisdom to override the black and whiteness of NICE guidance. tests. Yeah, I mean, a breast lump. I mean, some of those will go on private, so we weren't able to capture them. But there's not a woman comes into a GP surgery with a breast lump who doesn't think breast cancer and is going to walk out the door until something's going to be done about the breast lump. So these were slightly scary figures. Some reassurance to the figures was the amount of cancer actually in the referred and the non-referred. So each of these, if the GP chose to refer a patient with a high-risk symptom, they were much more likely to have cancer than if they chose not to. So the GP's decision-making process here is saying, I think we can safely spend some time or not make a referral and do something else to not identify cancer, actually worked. And when I think I might have to pop back a slide. I can't remember if my next slide gives you the overall figures. No, I didn't. But the overall figure was 11% of the cancer yield in the referred and 3.2% in non-referred. So GPs that were the GP wisdom was worth a factor of over 3. The snag is 3.2% in the unreferred was a bit too high. It was only 3.2 because there were a lot of rectal bleedings and a lot of dysphagics on the left. So GPs can and do use their clinical wisdom over and above the black and white and NICE guidance, and they use it quite well. But they probably need to turn the dial just a little bit to get some of the no referral group into the referral group. Again, thinking in GP land, we have this sort of naive but rather useful view that tests work. Tests do work, but they're not perfect. A chest X-ray will miss somewhere between 1 lung cancer in 5 and 1 lung cancer in 4 in Steve Bradley's systematic review. And when you go deeper into that, about half the missed ones are actually present. And the radiologist didn't see it. And now that makes me sound as if the radiologist being dim. Some of them are really difficult. And this is an area where AI, image interpretation, can really help. Yeah. The computer doesn't get tired. The computer can actually see these tiddly ones. So there is some help to that, and we'll probably find the chest X-ray miss rate, even when AI interpretation of these comes in routinely, that miss rate will drop. It fits that I think most of you are now using. There's certainly a lot of fit usage in London. The fit miss rate is somewhere between 10 and 16% when used as this. The two studies, Sarah's and Brian's, and they come out slightly different figures. It's and CA125 Garth's paper there, the miss rate again of 23% for CA125. Now, you might think that's awful. 1 patient in 4 that I do a cancer test for, the cancer test is negative. Well, actually, it's not that awful. It's better to do the test because you'll get it right most of the time than not to do the test. So what you just have to keep in your mind is that the test may mislead you. And you might have to repeat the test, or you might have to do other tests, or you may have to refer if you're still concerned that cancer exists despite a negative primary care test. Right, so this is a slide that I repeated from the beginning, and this is what you really wanted me to talk about. What will help? Prevention. I mean, it's still the stuff you've all known about, and that's smoking and avoidance of obesity and industrial chemical and community pollutants. The smoking, we've done well, we've plateaued, and tragically, the young women are smoking far too much. I mean, lung cancer is now an equal sex disease. When I trained, if you saw a woman with lung cancer, you didn't believe it. Now there's as many women as men getting new lung cancers. And that's simply because the young women are smoking. Tragic. obesity is bigger than we think. We sort of think of obesity as causing diabetes and wrecking hips, and by gum, it does do that. But actually, obesity is the second biggest modifiable risk factor for cancer in this land, uh, uh, with a number of hormone-related cancers having a considerable boost from you being obese. So breast, colon, a number of them are obesity related. Vaccination's great. HPV is going to be brilliant. We're going to get rid of as best we can a cancer by vaccination, and isn't that wonderful? Screening. I'm only going to put one slide up on screening. Screening works. The difficulty with screening is people sort of believe it's the answer to everything. They really do. I'm not speaking as a bitter cancer researcher who can't get grants because they all go to screening people. A lot does go to screening people, but I've had enough grants in my time. There is that sort of cloth-headedness that everybody will turn up for screening. All screening tests will work, and screening tests are much worse in terms of their performance to those that slide I gave you 2 or 3 slides ago of what chest X-ray and things are like. So screening works, but only a bit. And I've got a quiz for you. In fact, again, you can put I want you to put your hand up here, even though I can't see it, just that you have to sheep-facedly put it down when I tell you you're wrong. So each of you put up a hand with 6 fingers up, or 12 fingers up, or 18 fingers up, or 24 fingers up. I must have turned you into sloths or something. The answer is 6. 6% of cancers in this country are currently identified by screening, leaving the other 94 to turn up another way, usually via their GP. That is not to be used as an argument against screening. Screening works, but it is a minority subject. And there you are. There's proof. And I can't even see which line of screening is blue. There you are, nearly at the bottom of the percentage that are identified. But symptom awareness campaigns, these work. But do they work for long? I mean, I think when you see doctors on a screen saying, if you get out of breath, come and see your GP, they do work. They get, if you look at my second bullet point here, the public knowledge, if you measure it, goes up. GP attendances go up. GP referrals go up. Lung cancer diagnoses go up, and stage lung cancer go up. What's not to like? But it's all measured in the few months after the campaign. And when we did the second campaign, and I wrote the paper for the second campaign, actually, it got much less effective. GP referrals only up 10%, lung cancer diagnosis only up 2%, and stage 1 lung cancer only up 2%. Now they're up, but this suggests to me there's either a ceiling effect, whereby there's only so much education you can give that you'll encourage patients to come into the GP surgery with a cancer symptom or not. Or that it withers away in time. It's probably both. And we haven't a clue about the health economics. These cost a bomb to put out. So it would be fascinating to see if someday we'll put a slide rule of the health economics of this. I've got a guess, and you can probably work out what my guess is. Okay, clinical decision support. This is close to my homeland. I'm going to finish in about 5 minutes, so to give you time to talk. We have risk assessment tools for each of these cancers. I won't insult you by listing the body parts, but essentially every adult cancer, we know the symptom profiles for them. And we produce mouse mats. I've got one in here in my office. I'm actually using it. There you are. And then we tried calendars and coffee cups. My coffee cup's different, but and now we've got them in GP systems. and you have, or at least if you entered the trial, and in some places if you didn't enter the trial, and with some EMIS practices who've got cancer, you can actually get a pop-up at the start of the consultation, and that behind the scenes, the computer has calculated the risk of cancer based on the symptoms and the blood test results existing in the GP system at that moment, and will pop it up. And there's an example that the Cancer Decision Support tool has said that your patient has got a risk of colon cancer based on a funny PR and weight loss. And the difficulty with prompts is they're not always that popular. Every GP in the land will understand that feeling whenever another pop-up comes up, and I'm no different. And in fact, that's often the end result of WeGP. So you have to make the pop-ups very, very pertinent. So what we have done is we've now completed a trial, although I can't give you the results because I can't get them yet, of these pop-ups. And we did this trial in 477 English practices. And the pop-up came if the computer identified a risk of cancer up to 2%. And the main outcome will be stage of diagnosis. If these work, we should see a stage shift. Now, when it says results due 2025, the Cancer Registry has had an awful time. And they've been thrown from Public Health England to there and back and forth. The honest truth is they can't give us the data till late 26. So that I should have updated this slide. I probably won't be able to get you the results till 2027, but whether these things work. Cell-free DNA, GRAIL, this is the great liquid biopsy. They may help. The main gallery trial is a screening study, and it's completed data collection. I'm on the medical committee of it, but I do not know the results, so I cannot leak in any way whether the results will be successful or not. There have been another study that went down at the bottom of that Brad Nicholson did, of whether these MSEDs are useful in the symptomatic population, particularly in the 2-week wait referral board, urgent suspected cancer referral group, and they are probably some help, but whether they're quite good enough, we're not sure. But watch this space. I think sometime in 2025 there's going to be a very big announcement about whether these things work or not. Yeah, and I'm only mentioning passing artificial intelligence. I did mention it for chest X-rays. Image recognition is good. The image recognition software works. The other bit of, can you use artificial intelligence to sift through GP records and pull out symptoms in a better way than my risk assessment tools? Possibly, but it's actually some way away. I think it's a wee bit more hype than hope at the current time. I'm not saying that greater minds than I will not be able to get AIT to work in this clinical area. We also have the delightful or not delightful prospect of genetic risk scores, whereby I can have my blood analyzed and all my single nuclear polypeptides polymorphisms identified, and they will tell me where my risks of cancer are. Can you add a risk of cancer that I'm carrying genetically to my symptoms and do it better? The answer is maybe. So there will be a lot of genetic work coming in. There's massive ethical problems with that, but whether it's right to get my genome analyzed to see if I'm carrying all sorts of risks, thankfully I'll have retired, but that comes in, so I won't have to tangle with that ethical problem. Okay. Finally, the risk of cancer of raised platelets, it's something close to my heart because I first identified it in 2005 and it's taken off. You don't need to look at this in detail, but actually the risk, if a woman over the age of 40 has a platelet count over 400, is about 5%, and the risk in us blokes is about 11%. So if you get an unexpected raised platelet count, think cancer is the short answer. Okay, I'm going to jump over improved treatments because this is a diagnostic one, diagnostic talk. But let's just finish with let's not forget the patient. I know this is mocking secondary care, but we have to be very careful that everything we do in primary care is designed with the patient's interests and knowledge at heart. That's why we're here. That's why the NHS is here. So I just want to leave you with that we're here to help patients, and everything I've talked about in the last 40 minutes is designed around that. So nice platitude to finish with. I'm ready to take questions.
Thank you, Professor Hamilton, for walking us through your journeys so clearly. I think for me, it really just underscores our role in primary care and the importance of early detection for the patient, even week by week. So we've got quite a few questions, so I'll run through them. I think you've touched on some of these already. The first question was about AI, but I think we've heard your viewpoints on the future there. Next question, have your methodologies been used for non-cancerous conditions? Thinking about women's health, endometriosis, etc.
It's a great answer. I mean, you can do it, and we have done it. We've got a grant to look at celiac disease. And people have done it for inflammatory bowel disease. Again, what you want to do is target conditions that both diagnosis is difficult and delay matters. And for both of those, I think that is done. So yeah, it's easy enough to do. It's by all means clone me, take 50 years off me, and I'll do a whole lot more for you. But yeah, it can be done.
Thank you. Next question about headaches. Headaches are a headache because GPs don't have uniform access to scans in a timely fashion. Do you think we can expedite brain tumour diagnosis by refining our threshold for cancer referral or making scans more available to GPs for less significant symptoms, which I guess amounts to the same thing?
Well, I don't think it does. I mean, your question it's a great question. So congratulations. Even I'm being rude about it. You've offered me a choice. Do you test smarter or do you test more? And you only test more if you can test smarter, I think is really what your question is saying. You can do a bit of both. I agree with your question completely that headaches are very difficult. But we have to remember that a new presentation of headache in a 40-plus-year-old to general practice with no other features, the risk of a brain tumor is about 1 in 1,000. And it's quite possible that the risk of radiation from the CT scan adds up to that same level of risk over the 30 years or so that they're going to live after you've done it. So what we desperately need is a general practice test that will identify more subtle components of a brain tumor diagnosis. So there's some, count the number of animals in 30 seconds is one. And actually that works a bit. But you feel a bit of Burke, someone comes in and says, look, doctor, I'm worried about my headaches. I think I've got a brain tumor. Tell me how many zebras you can think of in the next 30 seconds. And they'll give you a strange look. But it does actually work a bit. Some people are looking at spectroscopy to see if you can use that to identify it, but the blood-brain barrier is quite good. So actually you don't see that much in the peripheral blood. So the current position is we do have to investigate more because we can't investigate smarter. But should we? And is the risk of having a CT scan greater than of having an undiagnosed brain cancer? It's balanced. Is the honest truth.
Thank you. I think we've kind of answered the next question. So somebody's asked what your thoughts are on expanding screening programs in primary care, or is the best approach system-based detection?
Oh, it's system-based. I think don't get me wrong. I was assiduous at doing my cervical smears, just like most GPs, and it wasn't because Kenneth Clark said my back pocket was made fatter by my doing it. It was because it was a good thing to do. I think the national programs work. And it's actually easier to collect the data. We've got fantastic data on mammography. We've got fantastic data on the bowel screening ones, and therefore you can target the non-attendees much better. So you can design leaflets in Urdu or whatever if your practice has got a lot of people with that language and whatever. And it's actually, I'm not dissing. I think we GPs do a great job. At least I'm 100% pro general practice, but there is something that is better done outside, I think.
Thank you. Next question is about the patient. So what role do you think patient awareness and self-referral play in improving early cancer detection? And I think they're thinking along the lines of public health campaigns, or can this be more of a hindrance?
Yeah.
Thinking of
Can I not answer that question and ask the question they should have asked? There's rude. That really is bad. I mean, I've sort of, the awareness campaigns, I've sort of said they work a bit, they might cost a lot, and the learning disappears. I think the bigger question, and please, I'm not being rude, your question was fine, is should patients be allowed to self-refer either to a specialist or to a community hub if they have symptom X? I personally think that is okay. Now, there are many other people, and probably some people in this call, will think, no way! Is that okay? I use the example of TB. In the 50s, if you had certain symptoms of possible TB, you could go into the chest x-ray unit, have a chest x-ray done. If you had TB, you entered the system. Now, what is the difference between that and a woman having a breast lump? The immediate concern, everybody put their hands up and say, well, what about the hypochondriacs who are up there every week and whatever? There are mechanisms to deal with the hypochondriacs, and you shouldn't let a small minority stop the good service for the majority. So I think taking women with the breast lump. Now, I add much to this consultation when she comes in and says, I've got a breast lump, and I examine the breast and I say, look, I'm worried or I'm not worried or whatever. I am going to make a referral. Now, I can offer her psychological support. I can tell her the exact risk. I can do things. But actually, she wants the mammogram and she wants the needle. She does. So why not make that easier for her? So I quite like the idea of self-referral with safeguards.
Thank you. Next question is about the gut feeling, which you touched on, and what extent does this play a part in early cancer diagnosis?
No, it's just impossible to study. Therefore, that's an interesting one. I say it's impossible to study, therefore, move on. I'm not going to move on. I'm going to diss myself now. It would be lovely if we could do it. My very earliest studies, the biggest marker of there actually being a cancer present was the fact that the GP had written a note, I think it might be cancer. So the GP's holistic summation. I don't actually think it's a gut feeling. I don't think it's just something tells you there's wrong. I think it's adding up tiny little bits of data which we can't measure. Yeah, we've all talked about them in general practice. You're a lecturer. You describe them. You see somebody's face, it's different. You know, you see the worry on their face and it's different. And I can't measure that. I can't put numbers on that, but it's real. It's an experience is so important. I can't make somebody aged 55. They all have to start at 25 and become 55. I mean, trying to suggest I'm 55, I'm not.
Thank you. This is an interesting one. So somebody's interested to learn how your research in cancer diagnosis changed your own clinical practice, if at all.
Oh boy! Well, firstly, it stuffed it because it meant that I could do less. It's I don't know. Well, I mean, I think being a researcher and being a clinician, you get better at both, and that's why the universities justify paying us decent money as clinical researchers. Yes, I know it's less than we get in general practice, but let's not go down that argument. I think it made me better. Now, can I really turn your question into a nastier question? Did it make you a better cancer diagnostician or a worse cancer diagnostician? probably better. I certainly would have been terribly embarrassing if I missed a cancer. I must have done. I certainly did before I went into it. I missed a 28-year-old cervical cancer, and she's dead.
Gosh, okay.
Yeah.
And this kind of follows on from that. Somebody's asked, are we trained adequately to identify early cancer symptoms as GPs?
Um, Probably the answer is yes, because there are so many competing educational interests. Now, cancer, I walk, talk, sleep, and breathe. So it's not fair for me to say yes, and everybody else does. How many weeks go by with a letter in the paper from some specialist group saying GPs know nothing about thyroid disease because they get one lecture on thyroid disease and then they'll forget it all. So thyroid disease is important, pregnancy is important, diabetes is important. I think, fortunately, it's one of the subjects we get enough experience of as we go along. There isn't a week goes by, Roa, without you having somebody where at least you think, could it be? Now, it might be just a very small C, could it be? It's not likely to be a big C, could it be? But there's hardly a week goes by. So we get pretty good at doing it. And there is a lot of it. There's a lot of education goes on. So I think the answer is I'll always ask for more, but actually it's not bad.
Okay. Next question from an anonymous participant. What about socioeconomic factors? How does this impact early cancer diagnosis and survival impact?
Did I say health economic factors? That's the first one.
Socioeconomic.
Yeah, it's a double whammy. Firstly, most cancers are more common in patients of lower socioeconomic classes because largely of smoking and booze, and to some extent obesity. So poorer people end up getting more cancers. And of course, they end up having more comorbidities at the same time. So they are patients with less resilience. And there's other practical factors. It's actually quite a bit harder for them to arrange appointments and things. If I'm a poorly paid, I was going to say poorly paid bricklayer, they're far too well paid. I'm trying to think about a poorly paid postie. It's probably quite difficult for me to get appointments off to see my GP to do this. And of course, if you're of higher socioeconomic classes, you're rather good at twinkling your way through the system. So I started off as saying it's double whammy. It's probably a quadruple whammy. That there is hardly a factor that works in the benefit of the lower socioeconomic classes. I can't think of one.
And somebody's asked, I guess this is follows on from that. What do you see as the biggest challenges in achieving early cancer diagnosis in primary care over the next 10 years?
Yeah, it's an absolutely marvelous one. I mean, if we're all friends, I can be completely honest. I think the biggest challenge is will primary care survive? Forgive me. I'm at the end of my career, and it's everybody at the end of their career is supposed to think the world's going to hell in a handcart. Well, I do think that, and general practice is so difficult. It's scary. So to me, the biggest issue is, can we maintain access to general practice? Because without access, we can't diagnose cancer. So forgive me, I've taken it up a level rather than maybe your questioner was thinking in the consulting room. What can I do? That will be a challenge. But actually, the challenge is getting a patient into the consulting room.
Thank you. I think we've got time for one more, and I think I'll pick this one, which perhaps was asked in jest, but they're asking if the answer is full body MRIs on everyone.
Well, I begin with the word starts with ball and ends in ox. Now, No. You find far too many incidental illness, and you cause far too much unnecessary worry, unnecessary costs, and whatever. There's really no good research evidence behind that form of screening, and there's all screening programs cause harm. Some do good. This is one that just causes harm.
Brilliant. I think that concludes the seminar for this evening. Thank you, Professor Hamilton, for joining us. That was really insightful. Before everybody heads off, I'm just going to share some final announcements for the evening. This is our final seminar for this academic year. Thank you for your attendance and feedback throughout. Please do explore the previous recorded seminars. There's an array of topics, including domestic abuse, digital innovation, sustainability, and so on. These are all available on the website, and along with the recording from today in the next few days. We welcome and value your feedback as we continue to develop the series for the next academic year. Please do use the QR code to share your thoughts on tonight's session, and also feel free to comment on any topic suggestions for next year's series. Thank you for joining us, and we look forward to seeing you again next year.